So let's start with the bladder. So I want to talk about three things about grossing in bladder. The most important thing here is the prostatic urethral margin. How do you gross for the prostatic urethral margin, both in the section of a frozen, in the setting of a frozen section, and also for permanence, and then briefly about urethral margin, and lastly about macroscopic tumor assessment in the bladder and why that's important. Okay. So the prostatic urethral margin, you can sample for either prostatectomy, a standalone prostatectomy where you're evaluating for prostate cancer, or in the setting of a cystoprostatectomy. So the prostatectomy, as you all know, is basically to assess for the presence of prostate carcinoma at the apical margin. So when we say prostatic urethra, we are essentially talking about the prostatic apex.
The people on Zoom, they don't see the slides.
Sorry?
The ones attending over Zoom, they said they don't see the slides.
Well, so because you logged in as not host, you can't really change the share settings.
I'm here as host. Is there?
Oh, wait. I didn't do the share you have. Sorry. How about now? Is that good?
And you're the see the
Yeah,
slides?
we can now. Thank you.
Sure. Okay. The cystoprostatectomy, the urethral margin is different. You're not really trying to look at any of the prostatic parenchyma. You want to look particularly at the urothelium in that setting. Okay. So when you get a prostatectomy specimen and you're sampling for the urethral or the apical margin, this is how you typically do it. So ink the specimen, and then you're gonna take a nice thick slice at the apex of the prostate, which comes out like this, and then you're gonna make perpendicular breadlock sections. Okay. So after you make these perpendicular breadlock sections, you're gonna lay it on its edge like that. So once you do that, the microscopic section is gonna look like this. And this is exactly what you want to evaluate the prostatic apical margin, because here's your ink margin and here's the cancer. And as you all well know, the cancer can be very, very close to the prostatic margin and still be called negative. That's unlike many other organs. In the prostate, even if it's less than 1/10 of a millimeter to the margin, if it's not actually transected, or if it's not actually touching the ink, you're gonna call it negative. So assessment of a closed margin is very critical, and you can only do that if you're making a perpendicular section like this, when you're able to see both the tumor and the margin in the same section. Okay? In the cystoprostatectomy, like I said, it's a different setting because you want to look at the urothelium in the urethra and see if there is urothelial cancer over there. So how do you sample that? If you do it perpendicularly, like you do for prostate cancer, let's say you shave off the apex and then perpendicularly section and submit it. The urethra is there somewhere in the middle. Most likely this section is the one that should have the urethral opening. But what happens when the organ is removed? The urethral mucosal membrane usually retracts a little bit up, proximally into the prostate. So this area on the microscopy, if you lay it out on its edge, it's gonna look like this. So that's where the urethra is supposed to be. So you see mostly a denuded area, and then you see probably some periurethral glands or prostatic ducts. So you can't really evaluate the urothelium or the presence of carcinoma there if you do this. So maybe you do it on pause, right? So that's typically how we do it. So if you do it on pause, you're gonna take a thick section like that, and then you're gonna lay it down, and any cancer you see that there is gonna be positive at the margin. But this is what you typically see, because again, the urothelium is retracted, and in most situations, you're going to see a denuded, irregular space. If you're lucky, you might see a little bit of urothelium here and there, but that's essentially inadequate for assessment of the urethral margin for the prostatectomy specimens. Plus, you're doing a gross disservice to the patient if he indeed does have prostate cancer. Because once you submit this on FOSS, if there is prostate cancer at the apex, it's gonna be this thick, right? So you're basically looking at this surface. So what about if cancer is very close to the margin here? You're not gonna see it. You're not gonna be able to evaluate it at all. So this is a wrong method of doing it for both incidental prostate cancer and for the primary purpose of evaluating the urothelium at the urethral margin. So the question is how to do it better, okay? You need to sample the urethral margin separately, either on the exterior, like so. So this is your cystoprostatectomy specimen that you received fresh, okay? And that's a bladder, that's probably the urethra up there, and this is the prostate. And down at the bottom, you can see the prostatic urethra. So if you're able to see it well this way, just hold it with a pair of forceps, and then take some sharp scissors and snip out a nice ring. That way, you will get what you need, just the urothelium and not the prostatic apex. And the prostatic apex is still intact if you want to evaluate for prostate cancer, and you're going to sample it exactly as you would sample it for a prostatectomy specimen. Okay. Sometimes what happens is, like I said, it retracts. So if you're not able to appreciate a nice little tube, a stump of a tube at the bottom of the prostate, what you can do is you can open up the specimen just as you would do for a routine bladder evaluation. So you do an incision through the urethra, but through the prostate, and it becomes a Y, and then you see this. And then you look at the bottom of the prostate, and you can see the urethra right there. So here, point to notice, what is actually the urothelial mucosa? You can see the color over here in the prostatic stroma. So that is all stroma. So it's sort of pale white. In contrast, look at the urothelium, the membrane. It's shiny, slightly yellowish. That is what you want to sample. If you're going to blindly hold something at the bottom with the forceps and cut through it, you may not see it at all because this thing usually pulls up. So you need to focus on the shiny yellow membrane and nicely snip it up. Okay, that way you're guaranteed to get the actual urethral margin. So this is how the section you submit should look, whether it's for frozen section or whether you're sampling it for permanent. If you're sampling it for permanent, I would advise before the specimen fixes that you take this piece of tissue, the margin, put it in a cassette, and then let the specimen fix, and also this one fix. So that way you won't have any problems with pliability. When you're picking up this piece of urothelium with your forceps, you want it to be somewhat pliable. If it's too rigid, you cannot snip it off with the scissors like that, right? So best done fresh. So then you will get nice urothelium at the margin, which you can evaluate for urothelial cancer and say whether it's positive or negative. Okay. So, like I said, it can be critical at frozen section evaluation because in frozen, if you don't sample it the right way, your attending is just gonna be asking for, or when you become attending, you're just gonna be asking for more and more deepers to look at the urothelium, which was never in the block in the first place. Okay. So the best practice is to sample the urethral margin separately on the exterior if you see it, or if you don't see it very well, you cut it open and then pick it up with a pair of forceps and sample it on the interior. Okay, please do not shave off the prostatic apex and submit it as the urethral margin. So urethra, I'll go quickly through this thing. It's not as critical because most of the time the surgeon is going to submit it separately as prone section. You just put the tissue in, make sure it's oriented so that you see a nice round tube over there, and that's all you need to do. However, sometimes the surgeon doesn't do that, and you need to sample it for permanent. Plus, you still need to sample the urethral margins for permanent, even if the frozen has been done, because the frozen section may show some urothelial atypia. Okay, and for you to assess whether that atypia is really cancer or not, it's always good to see the most adjacent section, the very next section on permanent. So that's the reason why you need to sample the urethral margin as a permanent specimen as well, even though a frozen margin has been submitted. So first of all, to do this, you have to identify where the ureter is. That's not as easy as it sounds. For those of you who have gross prostatectomy specimen will know that it may sometimes be difficult to identify the ureter. So what's the best way of identifying the ureter? You can either do it from the inside the bladder lumen or from the outer surface even before you open the specimen. So when you do it from the inside, this is how it's going to look like. So that part is the trigone. So that's the top of the trigone. So on the apex of apices of this triangle, you will find the ureters entering the trigone. So you can probe that, and using the probe as a guide, you can see the outer side of that area, and you can pick up the ureter margin that way. Sometimes identifying where the trigone is and identifying where that luminal opening is might be very difficult, because if a cancer occurs there, as in this case, and it's TURBT'd and chemotherapy has been given, the whole area may be fibrotic, and you may not be able to identify the ureteric opening at all. So in those situations, please don't keep poking and trying to find the ureter, because you're only going to create artificial divergence. So look on the outside and look for the clips. Usually the surgeons, when they cut off the ureter, they put white plastic clips, or sometimes metal clips. So that might help you identify. Once you identify the clips, try to probe it and see if you're able to enter the ureter from the outside. So what are these things? Is that the ureter? So that's the vast difference on either side. So that's not the ureter. So if you're going to probe through it, this is never going to enter the bladder, because this goes into the seminal vesicle at the back of the prostate. Okay. So the best practice is you do it on a fresh specimen, because again, pliability, once it's fixed, everything is rigid, and you will not be able to put the probe through either from the outside or the inside. And then once you've identified the margin, sample the margin, and also put in a section from the middle of the ureter and also from the ureteric orifice, for the same reason that we want to see if cancer is tracking along the ureter and going up to the margin. Okay. So finally, for the cystoprostatectomy or cystectomy specimens, we want to know why macroscopic tumor assessment is important, for obvious reasons, because you need to sample the tumor, right? And then there is also another important reason to accurately identify where the tumor is. I'll tell you why. So this becomes difficult because in many cases of bladder cancer, the patient obviously has had a TURBT, which is transurethral resection of bladder tumor. So you may not see a huge bulky tumor, and most patients also get chemotherapy these days. And so that will have cost just like therapy effect, retraction, fibrosis, and so you may not be able to see the tumor. So it's not unusual for you to get a cystoprostatectomy specimen that just looks like this when you open it, just an ulcer or a congested area, okay? And also a specimen like this where you don't see anything. So when you see something like this, there's no need to panic, okay? It's not like a wrong diagnosis was made and the tumor is gone. It's similar to the situation you may often see in rectal cancer, where most patients get neoadjuvant chemotherapy and you may not see anything. So you're obligated to sample the entire area that looks abnormal, whether it's congested or ulcerated or fibrotic. It's best to sample that entire area, okay? So to do appropriate sampling, obviously you're not gonna submit the entire bladder, right? So you need to know how to identify what is tumor. So that can get a little bit difficult because, as I mentioned initially, the patient is being treated, so you may get fibrosis, and you may also find areas of the detrusor muscle that are distorted and might mimic tumor. So you need to know how these look and what the layers of the bladder wall are. So you have mucosa or urothelium on top. Below that, you have a small layer of lamina propria, which you can see the edematous over here. And immediately beneath that, you have thick layers of muscularis propria. And unlike the colon in the bladder, the perivesical adipose tissue extends into the muscle layer. So that's why the muscle layer often gets distorted and it's not as regular as you might want it to be, okay? So here I have another image which shows you somewhat distorted irregular muscle bundles. You have what you can clearly identify as the detrusor here, but here the whole thing seems sort of congealed into some whitish walled structure. There's quite a lot of edema in the lamina propria. So could that be tumor or maybe just fibrosis? So those are the things that you need to try and identify. So what does actual tumor look like in the bladder? So this specimen is useful for demonstration because you can see there is a clear-cut tumor mass inside the lumen. And also you can see that it's invading the bladder wall right here and extending into the perivesical adipose tissue right here. So in contrast, you can see that this thing also looks whitish, but that's muscularis propria, okay? So here there is this more circumferential layer of muscularis propria, and here is the more longitudinal layer of muscularis propria. There's a subtle difference between that and this one, which is tumor, okay? So another important feature is the reason why you should be able to identify tumor is it's important for staging. Macroscopic presence of bladder cancer in the perivesical adipose tissue upstages the tumor. Okay. So here is an example where you see tumor, and you can clearly see a muscularis propria bundle over here, and this whole tumor appears restricted to the muscularis propria and above. Even though there is some contact with the perivesical adipose tissue, it's above the plane. So you can say that this is probably not invading macroscopically the perivesical adipose tissue. In contrast, this case, you can see there is a large obvious nodule, which is clearly beneath the plane of the muscularis propria. In fact, in this case, you can't even see any muscularis propria because the whole thing has been refilled with tumor. Here you can confidently say there is macroscopic tumor involvement of the perivesical adipose tissue, which will be so useful to the kind of pathologist who will then call it PT3B. Okay. How about in difficult cases? So in a case like this, you can see that there is clearly tumor here, and it's different from the muscle bundles, which is here. It's sort of shiny, slightly whitish brown. And then if you track the muscle bundle on this side, you can see there is the same sort of brownish tiny structure over here and it's interrupted over here. As I said, perivesical fat extends all the way into the bladder wall, so that your demarcation should be the plane of the muscular propria. The last muscular propria, that should be your plane that you will focus on, okay? Obviously, this section is curled. So what you want to do in a situation like this is you want to do an artificial line that connects these two areas, like so. Okay, so that's the muscular propria there, muscular propria over here. So if you do that, it might be possible that this is not macroscopically invading the perivesical adipose tissue. In a situation like this, your gross assessment should be, it's abutting the perivesical adipose tissue, but it's unclear if there is macroscopic involvement of the perivesical adipose tissue itself. So the pathologist, when you give a section from these areas, will be able to take that into consideration and then, along with the microscopic assessment, assess whether this is invading the perivesical path or still within the plane of the muscular propria. Okay, so that determination is important broadly. So in this case, it's clearly invading the perivesical adipose tissue here, but it may not be that obvious on growth, especially if you're going to draw a line connecting the muscular propria bundle from there and to here. So even in this case, if you want, you could say that it's not entirely clear, microscopic assessment is needed, okay? So what is this structure?
This small discount.
Yeah, that's the vas difference which runs along the bladder wall. It could be a portion of the seminal vesicle too. So best practice for a cystectomy is you need to do serial full thickness sections of the tumor. So instead of punching holes through the bladder, it's best if you kind of take your knife and serially section and then turn it and then see where the tumor actually is. Okay, and then you need to understand bladder wall anatomy in order to appropriately assess whether the tumor is invading the perivesical adipose tissue or not. And then the last thing is make sure you sample the diverticulate, because tumor oftentimes hides inside urinary diverticulum. So this is a diverticular structure, and this is another diverticular structure, and tumor is present over here. So it may not be so obvious in all cases, so make sure you sample any diverticular structure that you see, especially in patients who've had chemotherapy and you don't really see grossly residual tumor mass. All right, so quickly about prostatectomy. So the most important thing about grossing prostate is to understand the base of the prostate area, the bladder neck area, okay? And then I will also talk briefly about assessment of macroscopic tumor in the prostate, how to identify prostatic cancer from BPH, okay? So there are three important structures at the base of the prostate. One is the bladder neck, number two is the posterolateral base area, and number three is the seminal vesicle itself. So this is a typical prostatectomy specimen that you will see. So this thing is facing this way. So on the posterior aspect, you have the seminal vesicle and the vas difference. So that's the bladder neck area, and this whole part is the anterior fibromuscular tissue, okay? So you can see in the bladder neck area, it looks like a crater. So that's the urethra that's coming out from the bladder into the prostate, and these muscle bundles around in the periphery are the actual bladder neck muscles. So they are part of the detrusor muscle, okay? So there is likely no detrusor in this area. So if you sample just this area, you will not really be seeing the true bladder neck. So why is it important to sample this bladder neck area correctly? That's because margin involvement in the bladder neck area, like in this area over here, is an independent predictor of biochemical recurrence of prostate cancer. So that has to be appropriately sampled. Okay, and then the other important thing, just like in bladder cancer, is that if you find macroscopic prostate cancer in this area, it would mean involvement of an adjacent organ because that muscle is part of the bladder. That is an adjacent organ, so that will make it ET4. So here's another look. At the front of the prostate, this is the anterior fibromuscular stroma. This area is roughened because there is no pseudocapsule, unlike on the lateral aspects. And that's the bladder neck area. Here you can see it's a little bit different. So each case is going to be a little bit different, depending on how the surgeon resects it. Okay. And once you turn it so that you're directly viewing the bladder neck, this is how it looks. So what you want to do when you sample this area is to make sure you take a section that goes all the way through. Don't just take a superficial section like that, or don't just take a superficial section that misses the important areas on the periphery, which is actually where the bladder neck muscles are situated. So take a nice generous section all through here, and then you're gonna do perpendicular cuts like that, right? So this is what you see. You take a nice thick section over there, and then make perpendicular cuts and lay it down on a edge. So microscopically, this is how it should appear. Okay. If you're sampling through bladder neck, you should find detrusor muscles along with adipose tissue. So I know that's true bladder neck. So compact, large bundles of smooth muscle means that it's detrusor over there, okay? And the presence of fat. So if it's just going to be base of the prostate, I will not be seeing fat, and I will not be seeing these compact large bundles. I will just be seeing some smooth muscle with no fat. I know that's not going to be true bladder neck. If I see cancer in that area, I'm just not going to call it involvement of bladder neck. Or if I see cancer in an area which does not have the fat or these detrusor-like muscle bundles, and the margin is involved in that area, I'm not going to call it bladder neck margin is involved because the bladder neck tissue was not there. Sometimes the surgeon may not get it, but it's important to specify what exactly you see there. The margin is positive, just say the margin is positive at the base of the prostate. Do not say it's positive in the bladder neck, okay? Even though the section may be submitted by the person who grows it as bladder neck. You need to see this anatomy. So that's the importance of the bladder neck. And then what about the posterolateral base? Why is that important? That's important because that's where you have the neurovascular bundle on either side. So why do you need to be interested in the neurovascular bundle? Is because that is the most commonest region of extraprostatic extension of the prostate cancer and also margin involvement. So that needs to be sampled appropriately. Okay. So how do you identify that? So the posterolateral base region or the neurovascular bundle region is located, as the name suggests, in the posterior aspect of the base, just lateral to the insertion of the temporal vesicle and the vas repair structure. So this area is the neurovascular bundle posterolateral base area. So this should always be sampled, even if you're submitting only selected sections or alternate sections. Because this is the common location for cancer, and it's also common location for extraprostatic extension. So when you slice through it, this is what you will find, a little nubbin over there extending, if the surgeon has removed the neurovascular bundle, okay? Sometimes the surgeon might do what is called as a nerve sparing procedure. In those situations, they will not remove the neurovascular bundle. So why is that done? Because these nerves are critical for erectile function. Okay. So this is one of the common and major side effects of prostatectomy. And if possible, the surgeon will avoid or will prefer to leave the neurovascular bundle intact to avoid that side effect. Okay. In fact, in many European countries, the standard practice is to submit frozen sections from this area and ask us to evaluate whether there's any cancer here. If there is cancer, then they will go back and take out this area, the neurovascular bundle. But if the frozen section says there is no cancer there, they will leave the neurovascular bundle intact. That practice is not done in the US, not that pathologists are complaining, but it's just not done. So we need to evaluate this area if present on permanent sections. Okay. So if you identify cancer macroscopically, so you can say that this area, so this is homogeneous, slightly yellowish, that's probably cancer, probably this is cancer, this is cancer. So once you know or you suspect there is cancer in this area, it might be better to include all the slices up and down to this proximal and distal to this particular slice, even though your protocol will say submitting alternate slices is good enough. Okay, because this is a critical area of margin assessment. You sample extensively here, might be best for the pathologist who is signing out so that they can say whether it's truly involved or not. Okay. Another important thing to note here is when you are taking the bladder neck section and then making perpendicular section out of it, make sure you don't go too deep to include the posterolateral neurovascular bundle area, okay? Just if the process is like this, keep it like that, don't go too deep in that initial section because you don't want to inadvertently include this section in your perpendicular base margin submission, okay? The assessment is not gonna be ideal for margins in the lateral aspect if you submit it perpendicularly, okay? So make sure that you're aware of that. And seminal vesicle is important. So this is a mistake that's commonly done by many people who grow the prostate because they just don't understand the difference between an intravesical, intraprostatic and extraprostatic seminal vesicle. Okay. So involvement of prostate cancer in the seminal vesicle is critical for appropriate staging and prognostication. So it should be sampled appropriately. So to do that, you have to understand that there is an extraprostatic component of the seminal vesicle, which is this. So you get the prostate parenchyma, and then you get the extraprostatic tissue, and then the seminal vesicle. So this is extraprostatic seminal vesicle. However, this whole structure, the vas deferens and the seminal vesicle, they go into the prostate where they join together and form the ejaculatory duct, which means you will also have an intraprostatic seminal vesicle like so. Okay, so part of it is merged with the prostatic stroma. You can see the prostatic stroma here, and this part you still have a slight separation with the prostatic stroma. So this part is still extraprostatic, but this part is intraprostatic. Why am I talking about this stuff? It's because the tumor is upstage only if the extraprostatic seminal vesicle component is involved by prostate cancer and not the intraprostatic component. For example, if you have prostate cancer right here and you are looking at this section on the scope and saying, oh, that's seminal vesicle, it was submitted as seminal vesicle, and I see cancer here, so I'm going to call it seminal vesicles involved, so if that would be incorrect, because this is still intraprostatic seminal vesicle, and that's not considered upstage.
Dr. Murugan, I have a question. Can we tell if it's central or extra based on like the slides or only grossly?
Exactly. So you can tell because when I see a section like this, I know that's prostate, I know that's extraprostatic tissue, and I know that's seminal vesicle. So this area, if I see cancer here, that's going to be extraprostatic seminal vesicle involvement. Okay, so I can tell. But if it's not submitted correctly, somebody needs to go back to the specimen and submit a correct seminal vesicle And after it's been dissected out, it might be difficult to identify what exactly is extraprostatic at that point, so it's best done, during initial submission. So this one is intraprostatic, yeah.
So
you
it's
see-
inside?
Huh?
So it's that like, there is no separation between if it is intraprostatic.
Right, exactly. So you see here, so that's the prostate glands, and this is the prostatic stroma, wall of the femoral vesicle structure, cancer. So this is not seminal vesicle involvement by the cancer because it's in an intraprostatic location. So it's directly in the prostatic stroma and involving the intraprostatic seminal vesicle, which should not be upstage to be key.
Is it worth it to take a photo like that when you're grossing it, like how we do with like breast?
Sure, you can.
Just so you know, like have a gross core.
Yeah, you can do that. But like, the key thing is to understand when you're grossing what's intra and extraprostatic and submit appropriately. So in all these sections, these are serial slices of the same specimen. And you can see if you go from, this is the apical, like mid portion of the prostate, where the seminal vesicles have become ejaculatory ducts, and they are right in the middle of the prostatic stroma. Here you can see it's starting to separate out into vas deferens and seminal vesicle, and there's also a small separation. Here, part of it is starting to separate out from the prostatic stroma, but part of it is part of the prostatic stroma. In this section, it almost separated out completely, but you still see some attachment here to the prostatic stroma. You could sample this, but ideally you want to sample it here, where the whole thing is completely separated out. But you don't want to sample it too far away from the prostate as well, because the cancer may not extend all the way to the more distal part of the seminal vesicle. So you want to sample the extraprostatic seminal vesicle right at the point where it separates from the prostate. So the appropriate section to sample would be this.
So the basic idea is that the prostate cancer has to cross this back to go into the small intestine.
That's the basic idea, yeah. So in those cases, obviously, you will also see extraprostatic extension. So, making a diagnosis of seminal vesicle involvement and then saying there is no extraprostatic extension makes absolutely no sense. Please don't ever do that, because that doesn't, right? There might be rare situations in which the prostate cancer goes from here into the ejaculatory duct and spreads through the ejaculatory duct lumen into the seminal vesicle, but that's a very rare situation, okay? So that becomes tricky as far as staging is concerned. There are no large studies that tell us, like, if those tumors behave equally bad compared to seminal vesicle invasion, in which the cancer goes up through the prostate, goes into the extraprostatic tissue, and then enters seminal vesicle. My prediction is those cases will do better than the ones that go through the extraprostatic tissue into the vesicle, okay? But they are very rare. I've seen probably one or two. So the other thing about the seminal vesicle, when you're putting the section, is this can sometimes be the sole area of margin involvement, which means you have to nicely ink around the base of the seminal vesicle. So many times this area is not inked properly, so you just ink around the prostate and forget to ink this area. But please make sure this area is inked properly, and you can carry the same ink over and do the seminal vesicles too. So when you take a section like that, you will find ink on all sides of the seminal vesicle, and if I find cancer there, and I can properly assess the margins, okay? So best practice is, you need to identify the true bladder neck area to submit it properly, and you need to assess for gross tumor involvement in the bladder neck area, because that might change the stage. And then you need to sample the pay attention to the prostrolateral base area because of the important structures and the margin implications there. And this is probably the most important point here. Extraprostatic seminal vesicle closest to the prostate has to be sampled. Okay, so this one I'll go through quickly because it's not critical. It's important only for like one specific reason. Well, if you see a dominant nodule of cancer in the prostate, you have to document that accurately and measure that accurately because that's part of the synoptic checklist for prostate cancer. So sometimes I see gross description that are just templated with says no nodules, no specific nodules are identified. But then microscopically, I see a large area of cancer there. I'm like, okay, so this should have been seen grossly. And I can't really measure very well on the microscope because we submit already sections and we don't see the whole tumor. So identifying and measuring it during growthing is the best, that's the best opportunity. Okay, and then, we do have several research protocols, in which, it's good to identify prostate cancer correctly in the growth specimen, without having the advantage of microscopic examination. So it might be good to know, what is prostate cancer versus a BPH nodule on growth assessment. So let's take a look at that. So first of all, you have to know, the zones of the prostate. So you don't need to know all of that during grossing. You only need to know the peripheral zone and the transitional zone. Because any nodule in the transitional zone is more likely to be BPH, and any nodule in the peripheral zone is more likely to be cancer. Okay, so in these examples here, I can show you that this C-shaped structure over here, so that's the peripheral zone. So this is the anterior fibromuscular zone, urethra, and this is all probably, the white areas are not cancer, it's probably just stromal hyperplasia in the transitional zone, which is what you can see in this microscopic whole mount section. And so that's the C-shaped peripheral zone, and this is the transitional zone, which is not enlarged, and that's the anterior fibromuscular stroma. In this section, this has been taken after the specimen has been opened and pinned in a Y-shaped manner. So pay attention to all these little holes over here, because whenever you see those little things, those are actually the acini, right? So the acini that you're seeing on the microscopic image here, these are the holes. So why that's important is because once you see those, you know those areas are more likely not cancer. But once you see that it's more solid like that, especially the peripheral zone, these are the areas that are more likely to be replaced. The acini are replaced by a more solid growth pattern. That's a representation of that on growth examination. Okay, so you can tell a little bit based on that, but I will show you more examples here. So these are large nodules. Obviously, it's symmetric, it's circumscribed, fleshy, and bulgy. And it's, more importantly, it's in the transitional zone. And it's compressed the urethra like that. Okay, so this is more likely to be BPH rather than cancer. So you can see in microscopic representation that shows how BPH looks like in this growth specimen. Okay. In contrast, cancer looks a little bit different. So this nodule is somewhat infiltrative, is somewhat pale tan compared to this fleshy glistening structure, and it has replaced all these little acinar holes in the peripheral tube. So that one is more likely to be cancer, and that's the microscopic representation. So importance of identifying that is, of course, you need to measure it for the synoptic report, and also you know that this is a larger nodule, dominant nodule. So if this nodule has, let's say, 4+4 cancer, then my diagnosis is going to be 4+4, despite the fact that I might see pattern 3 in other sections. Okay, so the dominant nodule takes precedence. So if the dominant nodule has a higher grade of cancer, that's what I'm going to put as final diagnosis, because the patient's prognosis is most likely going to be dictated by the cancer over there, rather than incidental other foci of lower grade cancer elsewhere. So that's the other importance of identifying it grossly. And then, of course, the other thing is you want to sample this area more extensively because it's closest to the margin, and I want to see the relationship between the cancer and the margin and the extraprostatic tissue in that area. So if it's going to be as easy as this, then nobody's going to have a problem. But in many cases, it's really difficult to separate what's BPH nodules versus what's cancer nodules. So here in this first image, again, you can see a slit-like compression of the urethra. This is in the TZ, and it looks whorled almost like a leiomyoma. So most likely it's a stromal nodule there. It's whitish, so unlikely to be cancer. In here though, so I can say that that's probably BPH because it looks like that. And these ones are probably cancer, okay? But you can't really be completely sure. In this case, I can say like this is probably BPH. I already showed you this image, but let me show you one more. So this thing is cancer. So it looks very similar to that, but obviously it's cancer because it's occupying the entire prostate. And maybe these areas look a little bit dull yellowish compared to the more glistening ones. But you can see why it might be difficult to distinguish BPH from cancer in all cases. But you can use some clues, more solid like infiltrative nodules that are pale yellowish a little bit and are present in the peripheral zone. So those are more likely to be cancer versus nodules that you see on the left. Okay. All right. So this is a multifocal cancer, and you can see many of the acinar structures are replaced. So I will sample this area extensively here and here too.
Dr. Murugan, I have a question on the previous slide, the picture, you can go to that one slide. So the picture at the very top, the one that you said is BPH, but
This
also
Yeah.
cancer, like, no, the one next to it.
This one?
Yes, so like if I'm losing something like this, and like, should I treat it like, most probably I will count it as one big thing, like, what can we do, like, if there's like a change in color, so you want it to be like, so like described as two and not one, because the PDH part is kind of like within
Yeah.
the same.
Right, so if there's a change in color, it's best to not document it as a single dominant nodule. Because that type of growth assessment will be confusing on microscopy because we see sections that are like separated from each other, right? So if you're not sure, better to say you're not sure, or better to say no distinct homogeneous nodule is identified or something like that.
Okay, thank you.
So if you can like repeatedly look at the microscopy, go back to your grows, then keep doing that, you will have a better chance of knowing what cancer actually, it all comes from experience of doing that back and forth, right? And then you can also look at the MRI findings and the prior biopsies to see where cancer was actually sampled from. So that area is more likely to have the largest nodule. So if the MRI PIRA score is 4 or 5, and they say it's located in the right lateral prostate, that area most likely has cancer, and that's probably not BPH if you see a large nodule over there. Okay, so that's about the prostate. Let's move on to the kidney. We're good on time, so we finished 2 organs in an hour, and then we got 2 more organs, and we should be able to complete that in an hour. Anybody want to take a break or something? I know you've been listening to people say a lot. No?
I'm gonna grab some water.
Yeah. Yeah, so far, like, was that useful? Because I don't know if all these nuances are being created, whether, because sometimes it's hard to know what to focus on, right? Because people just tell you, okay, this is how you grow the specimen, you don't know what you're doing, what is the most critical aspect of what you're doing, so that's what I wanted to bring up here. So kidney, there are two types of kidney resection specimens that we will look at. Or I should say 3. You can also get like a nephrectomy for kidney cancer or a partial nephrectomy, and you can get a nephroureterectomy for urothelial carcinoma of the renal pelvis or the ureter. Okay, so there are several important things about grossing renal specimens that you need to understand, because grossing is so critical for appropriate staging and also for margin assessment. So I will go through each one of these in more detail. So let's start with nephroureterectomy. So this might be a more uncommon specimen compared to just partial nephrectomies or total nephrectomies, but when you do get this specimen, if you do not handle it appropriately, it can actually be a disaster. So we need to know exactly what to do when we get nephroureterectomy specimens. Okay, so an ideal nephroureterectomy specimen is gonna contain all these three components. Kidney, obviously, and then a long length of ureter, and at the bottom of it, you're also gonna see a larger piece, which is the bladder cup. Okay, sometimes the bladder cup might be small enough that you may not be able to distinguish from the ureter, but an ideal specimen should contain a bladder cup. So this procedure is done not for renal cancer, but for urothelial carcinoma that may involve either the ureter or the renal calyceal structures of the renal pelvis. Okay. So gross examination is critical for the final diagnosis of these specimens. So you got to know the location of the cancer, the focality of the cancer, the size of the cancer, and the distance of the cancer from the margin. The most important margin here is going to be the distal end, which may be the end of the ureter or the bladder cup. So all this can be determined only if this is growth appropriately. And to do that, the first thing you need to know is clinical history. So once you get a nephrectomy specimen with the ureter, most nephrectomy specimens also will contain some length of the ureter. Please check the clinical history and find out if this procedure is being done for renal carcinoma or for urothelial carcinoma, at least for suspected urothelial carcinoma. If you're not sure, then gross it as you would for a nephroureterectomy. Okay, I will tell you why. Because the prefixation is important. The way you open the specimen and fix it is going to be different for a nephroureterectomy specimen. Okay, submitting the bladder cup margin separately is going to be important for a nephroureterectomy specimen, and you don't do it the same way as you would do for a ureter margin in renal cancer. Okay, and also the tumor and normal tissue interface for staging purposes is going to be different than for a renal cell carcinoma. So I'll show you all these things in more detail. So first of all, we need to understand in nephroureterectomy specimen, the size of the tumor and the location can vary considerably. Okay, not all comers are the same, which may be true for renal cell carcinoma too, but the differences that you find in urothelial cancer involving the kidney or the ureter is going to be more varied, right? The gross appearance is going to be more varied. So for example, in this, you see a large tumor that appears to be in the kidney, but you can identify some papillary-looking structures that predominantly located inside a calyceal structure here. This one is a little bit more obvious. It's a larger, still a more proximal tumor, but you can see that it's occupying the entire pelvic structure and probably extending into some of the major calyceal structures here. This one is different though. This one is completely in the ureter, and I have not even given you the photograph of the attached kidney. So this is a large tumor and multifocal that's located in probably somewhere in the mid to distal ureter. Okay, and also the size varies considerably. So here you see multiple, more or less easily identifiable tumors in the proximal ureter, the pelvis, and also in the calyceal structure over here. So multifocal tumors that are more or less easily identifiable grossly. And here is another large tumor that's multifocal, but located entirely in the calyceal system, and there's part of it inside a branching calyx over here. This one is a lot more difficult to identify. Okay, there is no large tumor, but if you look carefully inside the pelvis, you see a little nubbin and some granularity in the pelvis. So the whole thing is probably has some urothelial atypia or incipient urothelial cancer, and that nubbin is most likely your target. So it can change. So why you need to identify these correctly is because obviously you need to know what is the distance of the tumor from the margin. which may be easier on cases where it's larger. But in a case like this, you open up and you don't really see anything distinctly. You need to be careful to assess where the tumor is. Now that you know grossly how urothelial carcinoma, the small varieties of which can look like, you can ideally assess them by looking carefully at the open urothelium. So the cancer in this case is actually here. Okay, so little granular structures. So in some cases, it might be even more difficult, so it might be really hard to see where the cancer is. But notice this particular area where it's a little bit shiny, it's a little bit elevated, and it's also a little bit coarser and granular. So that is the cancer. Okay, be aware that urothelial cancer can look deceptively innocuous, right? So
Would you please point again in the lower picture where the cancer is?
it's over here.
Okay.
Yeah, might be difficult to see, but that's what it is. Okay, so I kept talking about appropriately grossing it and prefixing. Okay, the prefixation part is important. So how do you actually do it for the nephroureterectomy specimens that have urothelial carcinoma? Okay, so you have to ensure adequate formalin exposure. So to do that, you should not bivalve the kidney from the lateral aspect, because the tumor in urothelial cancer is obviously in the medial aspect, either the pelvis or more distally. So in a case like this, if you start bivalving from the lateral aspect, which was unfortunately done in this particular specimen, it was bivalved, like the kidney was here, the ureter was here, it was sliced all the way up to there, and then it was put in the formalin bucket. That might be okay for a renal carcinoma, but what happens for urothelial carcinoma is that this part of the kidney fixes nicely, but unfortunately the tumor is not there. The tumor is over here, and you can see this one is pink and completely unfixed, and that's not going to be appropriate for microscopic examination. So when you look at microscopy of a tumor like this or like this, which is located in the pelvis, it's going to be like that. So I won't be able to say what the appropriate grade is, and staging also might be difficult because it doesn't fix well, and therefore it becomes friable, and you're gonna have like tumor spillover in all the different aspects of the specimen. So this is obviously a tumor spill into the hilar adipose tissue, and this should not make you upstate the tumor, but ideally the situation is avoided by properly processing the specimen. So how do you do it? Is it another way of not doing it properly? So you can't just fix the whole thing and then start opening the ureter, because what happens when the ureter is fixed, it becomes a rigid tube. Okay, so it's so difficult to cut through a rigid small tube to look for urothelial carcinoma. Okay, so the cancer might be over here. So these sections are suboptimal because it's so rigid. But then you might say, okay, what if I just breadloaf the entire ureter and submit it? That's also not appropriate because you won't even see the tumor. You won't know how many tumors there are, and you won't be able to tell me what the distance between the tumor and the closest margin is. So I won't be able to estimate the tumor size and focality. So don't ever breadloaf the ureter after it's being fixed. So at that point, a lot of important information is already lost. Okay. So when you do that, the formalin is not entering well into the ureter, right? So again, you will have this type of artifact inside the ureter. Smaller tumors, granular tumors like this will just spill over into the lumen, and you won't be able to estimate or evaluate it adequately for histology. Sometimes you may have real small tumors like that, and they may not fix well at all, and again, the same issue. So what you do is you first have to dissect into the ureter. Start cutting from the most distal end. Okay, just with a pair of scissors, just open up the ureter and then open up into the calyceal structure. and then bivalve the kidney from the medial aspect so that you get a specimen like this. One part of the bivalve the kidney should have a well-represented pelvic calyceal structure and the ureter and the bladder cup. Then let it fix, then pin it up and let it fix, then you will see beautiful morphology. Okay. So you want to ink the outer aspect of the ureter and also the hilar margins over here in case there is a cancer that's extending into the fat. This margin then becomes important, so don't forget to ink that margin. And then you have to ink the outer surface of the ureter for assisting the soft tissue margins there and also around the bladder cup. So the bladder cup is a little bit distinct because you have to sample it differently. You just don't take one on-pause section from the bladder cup margin. So this is best sampled perpendicularly. So this is a well-fixed distal ureter with the bladder cup. So what you're gonna do here is to ink the margin a distinct color at the edge over here. So when you ink this green and then you ink this a different color. The reason for doing that is you're gonna submit the bladder cup margin like that. So go perpendicularly and submit it on edge. So when you do that, the whole thing is gonna be urothelium. So I will not know which side is the true margin. So that's why it's best to differentially ink and say which side is the true margin. So this way, the pathologist signing out will know that this is the true urothelial margin, and if it's cancer there, that's gonna be constant. So this is the way to appropriately sample the bladder cup margin in ureterectomy specimen. Okay. So, any questions so far? So then I spoke about the tumor interface and how that's different from RCC. So in renal cell carcinoma, you're basically looking to see if the carcinoma originating in the renal parenchyma, which is this, is extending into the renal sinus tissue or the calyceal structure or into the perinephric adipose tissue, okay? But in urothelial carcinoma that's found in the kidney, it's the opposite. You're looking to see if the cancer that's present inside the pelvic calyceal structure is extending into the renal parenchyma or the perivesical fat, either over here in the hilum or on the other side in the perinephric area. So the interface and the relationship that you're looking for is different. So your samples have to appropriately represent those, okay? So here is the case of urothelial carcinoma of the renal pelvis and calyceal system. So in this one, I would need sections between the tumor and the renal parenchyma to see if it's invading the renal parenchyma, and also sections to see if it's invading the adipose tissue of the renal hilum. And the most important thing is I would need to see if the tumor is directly invading through the renal parenchyma into the perinephric adipose tissue, because that upstages it to PT4. Okay, so these relationships are important, and the route of the perinephric fat invasion changes the stage. So if I see a section from here I can see it's probably invading the perivesical or the perirenal adipose tissue, but it's just extending from the calyceal structure into the hilar fat over here, okay? This is not the same as the tumor penetrating all the way through the renal parenchyma into the perinephric adipose tissue. So those are different things. So grossly, if you don't explain this correctly, the pathologist who's signing out will not know whether this one should be a PT4 or a PT3. So it becomes important, right? So let me show you some examples. So that's a tumor that's involving the upper calyceal structure over here. It's probably going into the fat, but also notice this tumor is penetrating all the way through the renal parenchyma and maybe involving the perinephric adipose tissue right here. So a section through that is critical to assess for PT4 stage. Okay. So in contrast, this is a tumor that is involving the perinephric adipose tissue, but through a different route. Because here it's coming and involving the adipose tissue close to the hilum and not going through the entire thickness of the renal parenchyma. So distinction between these two is important. That is why I was saying sampling the tumor interface with adjacent tissue and appropriately labeling them is important for appropriate microscopic examination and staging.
So Dr. Murugan, the first example was PT4 and the second example PT3?
Correct, yeah. So this would be a PT4 because it's going through and involving the bladder program. Okay. So in summary, the best practice for nephroureterectomy specimens is number one, to check if the resection is for urothelial carcinoma versus renal cell carcinoma. And number two, once you do that, you open the ureter and pelvis longitudinally while the specimen is fresh. Okay, and then you carefully ink the bladder cuff margin distal edge and sample perpendicularly and put it on edge. And then assess for renal parenchymal invasion and perirenal fat invasion via the renal parenchyma and document that in the growth description. Okay, those are the important things for nephroureterectomy. So nephrectomy specimens. So these are specimens that are done for primary renal cancer and not for urothelial cancer of the kidney. So there are things that we need to document carefully in these as well. So that's important for staging. And for staging, you have to accurately document the tumor focality and document the relationship of the tumor to the renal sinus, perinephric adipose tissue. But here it's the other way around, right? Cortex to the renal sinus or calyceal structure or perinephric adipose tissue. Okay. So let's first talk about tumor multifocality. Why is this important to assess properly in nephrectomy specimen? Number one reason is the accurate measurement of tumor size determines what stage you're going to give it. So for tumors that are confined to the renal parenchyma, size is the only parameter that differentiates between PT1A, 1B, PT2A, and 2B. So to accurately measure the tumor, you need to know what the tumor mass is made of, whether to count those as multiple nodules or single node. Okay, I will show you some examples. And that's also important for an ancillary staging parameter. If you see multiple nodules or true multifocal tumor, you're going to give it an M stage. Okay, so determination of multifocality is important for these two reasons. So with that, let me tell you that true multifocality in RCC is extremely uncommon unless the patient is syndromic. So this is an example of a patient with VHL syndrome where they have multiple clear cell RCCs distributed throughout the kidney. But again, this is an uncommon situation. Most sporadic clear cell RCCs, which is the most common type of RCC, is going to be unifocal single mass. Okay, remember that. The situation is different for other types of renal cancer, especially papillary RCC, which is the second most common type of RCC. In this situation, multifocality is not that common, especially in not that uncommon, especially in patients who have end-stage renal disease or some other type of chronic kidney disease. They may develop multiple papillary RCCs, as you can see in this particular example, where the color is more pale tan yellow compared to the bright yellow of the clear cell renal carcinoma. And often these are hemorrhagic, and often these are all peripherally located with exotic masses into the pushing into the perirenal adipose tissue. Okay. So let's then figure out how to determine if a clear cell RCC, again, the most common type, is truly multifocal or not, with the knowledge that true multifocality is very rare. So in a case like this, where you get a humongous mass kidney, so most of you are going to say, okay, that's a large mass, I'm going to measure diagonally largest diameter from there to there. I do see some little nodular structures here, but come on, that's so close enough to the main tumor that I'm just not gonna think of that as a distinct mass I'm gonna measure. So that's easy, okay? But in some cases, it might be a little bit more difficult, like here in this other example. So there's a large mass over here, and then two medium-sized nodules over here, and then a little nodule over here, and a little nodule over here. So the question is, okay, so is this one large mass, and should I say that's another smaller mass, or should I measure the whole thing? So it's slightly more difficult than this example, but I guess it's not as difficult as some of the other things I'm gonna show here. So there seems to be a distinct nodule right there, which seems to be at a fairly longer distance from the main tumor. So most people will try and measure like these two or describe these two as, okay, I see one distinct large mass, which measures whatever, 5 centimeter, and then another mass, which is 2 centimeter away from the main mass, which measures about 1 centimeter or 2 centimeters. Okay, so that's not correct. And here is another example where you find a much more spread out cancer with multiple nodules, which are varying in color all through the kidney, and some nodules over here and some going all the way up to the periphery. So question is, how do you measure this? And do you say there are multiple tumors and measure each one separately and submit each one separately? So you can see it can get real complicated real quick. So you need to understand, number one point that I already mentioned, that true multifocal RCT is failure. And then number two, why do we get this pseudo multifocality? That's because of the vascular network of the kidney. So the kidney's got an intricate arcuate vascular network, and clear cell RCCs in particular love to get into the veins. Okay, so this is the arcuate vascular network of the kidney, extending or all the terminal branches of the renal vein and corresponding renal artery. So if you see an example like this, so this tumor probably is entering the renal vein, one of these branches somewhere over here, and then these two little nodules are probably the tracking of the tumor, and when you cut it open, you just find it over here and here. So that's not really multifocal. So these two are this extension of the same tumor through the renal vein branches. Okay. And here's another example where it shows the tumor located bang in the middle of the renal vein or one of its branches. And a more extensive example where you find several nodules similar to one of the examples I just showed you. So there's a large mass over here, and all these things that you find are basically tumor entering into the renal vein branches and then popping out in the section that you get just cut through. Even this one is just a spread along the renal vein and not a true multifocal nodule. And then I have the most elaborate example. This is the one that I put up in the case of the week, I think the second week, and most of you had difficulty in identifying what this is. But now you can understand that this is a spectacular example of tumor basically following the entire pattern of the arcuate venous structure of the kidney and spreading out. So this is one tumor. Okay?
Dr. Murugan, so how should we measure the second, this one?
So I will tell you in a brief moment, but you should make serial sections. So basically, you're trying to find connections. You're trying to ascertain that all these are actually the same tumor. So whatever is a close nodule, I would suggest you measure all of these together. Whatever is a nodule that's further apart, you can say that this might represent a vascular invasion instead of calling it a multifocal tumor. So yeah, I'll come to that point in a moment, but let's also talk about large venous masses. So you saw all these smaller nodules and snake-like extension into the renal vein branches. But of course, the tumor can go the other direction and go into the main renal vein itself, and sometimes even into the IVC. So here's an example of a tumor that's multifocally spread into the renal vein branches and also into the main renal vein with a huge mass, the tumor thrombus in the renal vein. Okay, and here's another example of renal vein extension. And the same phenomenon can happen in the lateral aspect of the kidney as well. So here you can see a nodule that's spread along the venous structures that drain from the perinephric vat through the kidney into the renal vein, and the tumor can extend out through that too and form an little LVI over here, and that LVI can expand into a large perinephric renal mass as well. So it can form large masses either on the more proximal end or in the most distal aspect of the venous structure. So that's something to remember. It's not just restricted to the kidney itself. Okay. So you also want to know about perinephric fat invasion. Okay, this is another thing that upstages the tumor, and growthing is important to identify what is true perinephric fat invasion and what is not. Many times, renal cancer can grow exophytically from the cortex outwards, but they are still going to be limited by the renal capsule. So how does that look? It looks like this. So here's a tumor that's arising in the renal cortex, and then it's pushing out into the perirenal fat, but is still confined by the renal capsule. Right? So please don't describe this as perinephric fat extension of the tumor. That's different, because that would essentially mean PT3. Circumscribed encapsulated bulging of the tumor is not considered perinephric fat invasion. You need to see the tumor in an infiltrative contact with the perinephric fat to make a diagnosis of perinephric fat invasion and therefore PT3. And this is not one such example. And these are not such examples either. So these are varying gross presentations of tumor that's just bulging into the perinephric fat with an intact capsule, So this one is even more like perinephric fat invasion looking, where you can see is still like nicely circumscribed, and microscopy you should see some capsular structure like that. But the problem is, in such case, if a section is submitted like that, and the gross description is, this is a tumor in the perinephric fat, Tau is not going to know anything about the relationship of this to the kidney itself, and probably going to call it perinephric fat invasion. Okay, so we don't want to do that. So true perinephric fat invasion is like this. So that's some renal parenchyma, and this is all perinephric fat. This is an infiltrative, aggressive appearing tumor that's involving the perinephric fat. The same situation here, infiltrative, aggressive appearing tumor, no capsulation. So this one is most likely involving the fat. So this is what grossly I would call as true perinephric fat invasion. And here's another example too. Okay, so let's come to the other side, the renal sinus fat. So here things are a little bit different because there is no limitation by the renal capsule. Okay, so tumor can directly contact the renal sinus fat much more easily than they can do on the outer aspect of the kidney. Okay, so here is a easily diagnosable example where you can see clear-cut invasion of the renal sinus fat by this tumor. But this is not a situation that we encounter commonly. The situation that we do encounter commonly is when you have a nicely circumscribed tumor, okay? So in most situations, if a tumor is larger, like any PT2, so renal cancer, the PT2 stage is divided into 2A and 2B by the size, right? Anything between 7 and 10 centimeters is going to be PT2A. Anything that's greater than 10 centimeters is going to be PT2B. The take-home point here is that any renal tumor that's gonna be that large, it's very unlikely for it not to involve the renal sinus adipose tissue. Because if you consider it, the renal cortex is only a big, like it's maybe 4 centimeter. Tumor might be able to grow, like expand it a little bit, but once it grows beyond 7 centimeter, it's extremely unlikely that it's leaving this area alone, right? So here is a rare example of a large tumor that's partly exophytic, and it has managed to expand the cortex so much that it's still confined to the cortex. So that might be a true PT2, but in most situations, it's not going to be like that. So whenever you see a large tumor, it's most likely that if you're not calling it invasion of renal sinus fat, it's most likely that you've missed it because it's not being grossed appropriately. So these large ones, they do a pushing invasion into the renal sinus and they kind of replace the renal sinus fat. So in these two examples here, you can see, I can hardly see any renal, maybe there's some renal sinus fat over here, and this is basically some hyaluronic fat, but this whole area is very close to the pelvis itself, and I see only tumor, there's no fat. So this would grossly, I would say, the tumor has replaced the renal sinus fat, which would automatically make it into PT3. Okay, so that's important. And here on this example, you can see the superior aspect of the renal sinus fat is completely disappeared because the tumor has replaced that. Only the inferior aspect of the fat is visible. Okay, so why it's important to mention this when growing is because once it's replaced the entire thing, microscopically you may not see it. Okay, so this is an example again, grossly you can see that involving the renal sinus fat, but microscopically you may not see it. Another example here, this is even more dramatic because here you can see the entire fat is gone. The tumor is clearly in the renal sinus. But when a microscopic section is submitted, any of these cases may just look like this under the scope. And you may see the fat over here, and you may see the tumor over here, and you're like, okay, that's probably not involving the renal sinus fat, I'm not gonna talk. But then the gross specimen actually shows this. So this is what needs to be documented in order for us to appropriately stage these specimens. Okay, and then the last thing I want to say is there are two situations in which you might see a renal tumor looking like it's being capsulated. Okay, so it's not really, the renal tumors usually don't show true capsule unless they are either like pushing into the renal capsule and growing exophytically, or in these two situations. Okay, the first situation is when it's growing inside a renal vein or its branch. Then the wall of the vein itself looks like a capsule. So whenever you see a rounded structure that looks like there's tumor over there and it's encapsulated, you're probably looking at a renal vein with tumor in it, or a renal vein branch with tumor in it. Another example, nice rounded nodule with a capsular structure, that's renal vein invasion. Okay, and microscopically, this is what you will see. So that's renal vein invasion. And then the other situation where you might see a sort of capsule is when the tumor is pushing against the pelvic system or the pelvis in some cases. So here you can see a normal pelvic system in the inferior aspect. In the superior aspect, the tumor is over there and it's compressed the pelvic system on all sides, making it look like some sort of a capsule. Another example over here, so this is the pelvis and it makes it look like a capsule. So why am I talking about this apparent pseudocapsule of the tumor? Number one, I already mentioned, so when you see this, you want to make a gross diagnosis of probable renal vein or renal vein branch extension. And number two, you want to appropriately assess whether the tumor is involving the renal calyx or not. Why? Because this is also important for staging. So it upstages the tumor to PT3A, irrespective of like renal sinus or perinephric fat invasion. However, we want to make the diagnosis of renal calyceal invasion only if the tumor is truly within the calyceal system or involving the urothelium of the calyceal system. Oftentimes, you only see tumor abutment, like in the examples I just showed you, okay? So there are a couple of examples that I will show you in a moment, but these are similar to the examples I showed you earlier where the tumor is just pushing up against the calyceal system, here too, pushing up. So this is not to be considered either grossly or microscopically as renal calyx involvement, okay? So in microscopy, you will see such a structure. This is denuded urothelium, and the tumor is just pushing up against it from the outside. So you want to call it calyceal invasion only if it involves the luminal aspect. And these are a couple of examples where you can clearly see. So this is you can trace the calyceal system over here, and then you can see the tumor has clearly entered that. Okay, and microscopically, you will see something like this, when the tumor is actually inside the lumens of the urothelium. Now, another example, if you look carefully at the top over here, so that's the calyceal urothelium, and the tumor is actually growing inside of it. So that would make it big. So in summary, for nephrectomy, what are the best practices that you need to follow for appropriate microscopic assessment and staging assessment? You need to know true multifocality is rare, and whenever you measure the tumor and you see multiple nodules, you need to measure all the main mass and the adjoining nodules as one tumor, okay? And then if you're not able to do that and you're not sure if it's adjoining or not, you try to look for it in different planes. At some plane, you should be able to see the contiguity. Then you can measure it in that plane. If you don't see that and the nodule is more distant, then you can call it as possible LVI. Before you make a diagnosis of IC multifocal renal cell cancer. And then renal sinus fat replacement must be documented on both exam because we may not always see on microscopic exam. Perirenal fat area, you should always mention that it appears circumscribed and probably encapsulated, so it may not be true perirenal fat examination. And we just spoke about how to grossly diagnose calyceal involvement. Okay. So finally, another important aspect about the nephrectomy specimen is margin. So what are the margins we are supposed to see in a nephrectomy specimen?
The ureter, the soft tissue, the vascular.
Yeah, the vascular margin, the ureter margin, and the third one that most people forget is the hilar soft tissue margin. Okay, that is also a true margin for nephrectomy specimen. By far, the most important margin here is the renal vein margin, because that's what these tumors tend to enter into, and adequate assessment of those margins. Okay. So most large tumors, they involve the renal vein. So this is a humongous tumor that's grown into the renal vein and completely replaced the venous structure, right? So the whole thing is a tumor over there. And here's another example that clearly shows you there's a tumor thrombus that is protruding in the lumen of the renal vein. So this is an example. These are examples that you not infrequently encounter in RCT specimens. So what is the true margin here? The true margin is the circumferential edge of the vein itself. So what do I mean by that? So you see this example where you can see again a large tumor that's extending into the renal vein and then protruding outwards. So where is the true margin here? Is it here? Is it here? Or is it somewhere else? So if you look carefully here and follow the wall of the vein, it ends right there. The only true margin is right here, nowhere else. Okay, so don't please sample this as en face of the renal vein margin and commit a section this way. That's not the true margin at all. True margin is right there. That's what you need to sample. Again, in this example, this is not the true margin. True margin is at the wall, the edge of the renal vein over here. So the best way to do this, when you have a separate thrombus protrusion and the wall appears distinct from that, is to sample just the wall alone. So you can just take a pair of scissors and forceps and pull this margin up and cut it like a circumferential ring. Just sample the free margin and submit it as the true margin. Like you should be getting sections like this. Or if you're not able to make the whole ring, you should at least be having free margin sections like this. Sometimes, I'll come to that, but I just wanted to re-emphasize that it's completely inappropriate to shave off the edge and submit it as a margin. Okay. Sometimes the tumor is so tightly adherent to the vein margin that you can't do anything but submit it on spot. But when you do that, make sure you're cutting at the level where the vein ends and not like beyond that. Okay. So here's an example where you find like a ring of vein completely occupied by tumor, and there's like a solid structure on the wall. It's probably involving the whole thing. So in here, as the same example, so this one is okay as a non-cost margin. So the whole purpose of doing this is because the truly positive margin is a margin where the tumor is involving the wall of the vein. Okay, if I see a tumor involving the wall of the vein like this, that's the true positive margin. So that's why we need to submit it appropriately. And then the next margin will be the hilar soft tissue margin. This is something that is uncommonly involved, but frequently ignored. This is important in cases where you have a large nipple tumor. Okay, so for example, in a tumor like this, so you can see the hilar vessels and probably ureter, and this is the hilar pad, soft tissue. This is a tumor entering the renal vein. So you will sample this margin, of course, and then you will sample some perinephric dermatopathia, but please don't forget to sample here, because that's the closest relationship to the hilar soft tissue margin. Okay, so this is not common, but try to keep it in mind where you're submitting sections for you.
Excuse me, to the previous case, we take a shape or we take a perpendicular section to the
It
tumor?
depends on how far the tumor is away from the margin. If it's close enough, it's always better to do a perpendicular than a shape. So finally, what about the artery and ureter margins? These are not critical at all. Even if you miss them, it's okay. For one thing, the artery margin is just like a super silly margin to submit, because tumors never enter arteries. It's got to, if a tumor is supposed to enter the artery, it's got to push up against 120 millimeters of mercury pressure. That no tumor is that powerful. It's never going to do that. The only situation where the artery margin is important is when you have maybe an adventitial tumor involved. So for that, you can submit that margin. Ureter is the same thing. For renal cell carcinomas, rarely you might find a super aggressive carcinoma that enters the ileal system, like the examples I showed you, and then come into the ureter. Those cases it's important, but typically on urothelial carcinoma, only for urothelial carcinoma, this margin is critical. Okay. So here's an example where you find a ureter margin, and then adventitiously you find a renal cell cancer involved to the steroids. Okay, so best practice for margin is when a tumor thrombus is present, so carefully examine the margin for tumor attachment. Okay, if the tumor is attached to the margin, you can sample it on spot. If the tumor is unattached to the margin, sample the free margin of the vein circumference. And then don't forget the hilar soft tissue margin, and then we just spoke about the artery and the ureter margin. So before we go to the testis, one final thing, I wanted to just mention how to identify a sarcomatite change, because this is completely dependent upon the person who's grossing or sampling, and is so critical for grading and as a prognostic parameter that you need to be able to identify and sample it appropriately. So this is quite different from the typical appearance of clear cell RCC. So low grade RCC, even higher grade, grade 3 ones usually have this bright yellow appearance. But when it undergoes sarcomatite change, it's going to look like a sarcoma, which is and slightly yellowish and fleshy, like here. So in this example, probably these areas will show more conventional RTC, and this area is probably sarcomatite RTC. So I would extensively sample all the areas that look and fleshy like this. And another example here where you can see the peripheral nodule right there, where it's likely to be sarcomatite change. So sample that, and this is a microscopic example, of course, of epithelial to different cranial parts. So finally, testis. This is a specimen that we don't really get to see too often. But I will say that our part of the country is probably where you'll get to see more testicular specimens than other areas, because these cancers are more common in people of Northern European or Scandinavian descent. And the Minnesota, Wisconsin population has a large number of people with Scandinavian. Therefore, we do see some testicular probably once a month. So what to do when you get a testicular specimen? The first thing is to sample the margin, okay? So it's similar to the urethra margin I was talking about for sister prostatectomy specimens, but for a different reason here. You need to understand that that's the only margin in the testis that's relevant. None of this is a margin. None of this is a margin. So the only margin relevant is because the surgeon cannot take anything more. So they just pull it out and then you get the tunica surrounding the testis. So that's not a true surgical margin because no scalpel blade has gone through it. So if no scalpel blade has gone through it, that's not a true margin. Okay, so the only true margin is up here. So what you do is when you get the specimen fresh, before like cutting through the specimen, just cut off on pass margin of the spermatic cord and put in separately, preferably not in the same container, because once you cut through the specimen, the tumor is going to be so friable with seminomas, especially that they're going to float all over and probably cause some floater contamination. And this is an example of floater. So you see a spermatic cord, some pampiniform plexus of wings, and then you see a floater over here. In this case, it's on the outside next to the ink. So it's not going to be difficult to say it's a floater, but in some cases, little clusters of cells can be found in vessels, and they may look very much like a true tumor presence. So better be careful. Okay, like I said, you may or may not want to ink the peritonealized surface because that's not a true margin. The only situation, extraordinarily rare situation, when there are other margins that can be involved in testicular tumor is if the tumor is so aggressive that it has penetrated through the scrotal wall. So in those situations, obviously, these areas, the entire skin margin, that becomes a true margin. Okay, so that's a very rare situation. So here's a cut open example of this case, where these are all true margins because these are skin margins. Okay, so how do we sample so that archaeotomy specimen can be staged appropriately? So the first thing to do is to properly identify what the spermatic cord is, especially the base of the spermatic cord. Because if a tumor involves the spermatic cord, it's going to be upstaged to PT3. Okay, so here is a graphic representation of the testis with the cord structure. So basically, the cord structures contain these pampiniform plexus of veins, some connective tissue around that, and the vascular. Okay, but the whole thing is like, where does the spermatic cord actually start? that's quite ill-defined, because there is no clear anatomic boundary there. Okay, so this is an actual specimen, where we can see on the outside that this part is the spermatic cord, but we also have the epididymis over here, and then the vas deferens that's going down and then coming back up, and all the hilar soft tissue. So the hilar soft tissue is not considered part of the spermatic cord. So the problem here is trying to decide where does the hilar soft tissue stop and where does the spermatic cord start. So in a cut open specimen, you will see why this is a problem more clearly, because this is all hilar soft tissue and this is all spermatic cord. So where is the line? Is it here? Is it here? Or is it up here? Okay. So in a situation where the tumor invades the spermatic cord, that would change the state. So you need to know if the section submitted actually represents the spermatic cord. And there's no way you would know if the section is submitted from here, whether it's invading spermatic cord or not, because no true microscopically observable elements will be present. So the best time to assess whether spermatic cord extension is present is when you're grossing the specimen, okay? So how do you identify that? What are the landmarks here? So the landmarks are where the cord becomes a single structure. And I would say it starts right here. So when this triangle becomes like parallel like that, so you draw a line straight there. So that would be the area where the true spermatic cord starts. So in this case, I know it's a little bit difficult to say, but I would say probably the spermatic cord started over here, and I would roughly estimate that this tumor has involved the spermatic cord, okay? So this area would still be the hilar soft tissue, and anything beyond that will be spermatic cord. Having said that, I would say there are a couple of microscopic clues that you can use, especially if the tumor is not too large. So those microscopic clues are, number one, the presence of cremaster muscle. So the cremaster muscle is the one that is responsible for cremasteric reflex. And that muscle is extended from the pelvis, and then it attaches itself to the spermatic cord proper. Okay, so it attaches itself somewhere over here. So any section where you see the cremaster muscle represents true spermatic cord. Okay, and also most sections that show you the pampaniform plexus of veins and a singular cord structure. In most of these areas, you will see the vas deferens as like it'll be looping around. So when you give a section, you might see multiple like circles of vas. So that's not spermatic cord. When you see a singular cord structure, that's probably spermatic cord. So those are the two microscopic clues that you can use. But again, like I said, gross assessment of where the spermatic cord is probably the best thing. Okay, so usually you find adipose tissue in the hilar soft tissue, but sometimes you may not find it. In this example, you see some adipose tissue, but most of it is other types of connective tissue in the epididymis. So then let's talk finally about the hilar soft tissue. So why is this important? Because in the new AJCC staging system, involvement of the tumor in the testicular hilar soft tissue upstages it to PT2. Now, involvement of the spermatic cord becomes PT3, but involvement of the hilar soft tissue makes it PT2. So this means you need to see tumor extending outside of the tunica covering. Okay, so here in the testicular hilum, the tunica turns over and goes to the other side, the visceral peritoneum. So there is no tunical structures right here where the reedy testis extends outside to form the epididymal structure. So if a tumor is present in this area, then you may have some difficulty. So let me show you an example. So this is a tumor that's present in the hilum, and obviously a microscopic section is going to be submitted from here to evaluate for hilar soft tissue extension, and it might become a little bit difficult because unlike in the prostate, fat is not a constant presence in the extratesticular tissue. So here's a microscopic example. Okay, so that's the tunica, and this is where the reedy testis exits out to form the epidermis. These are the efferent tubules. So let's say there is a tumor over here, okay? So this would be a PT1, so it's kind of circumscribed over here, it's not extending into the hilar tissue. That's not gonna be a problem. But what if you get a tumor like this? Probably the same example that we saw in the growth specimen. What if you get a tumor like this? So how do you evaluate? So the principle here is you roughly use the tunica on either side as a guide. So it's coming over here, it's coming over here. Estimate if this is beyond the plane of that. Like if you think that's beyond the plane of that, so that's gonna be a PT2, which means when grossly sampling it, I need to see the tunica on either side. So sample it appropriately so you get proper tissue on either side of the tumor if it's located in the testicular hilar region. Okay, and then a couple of other things about uninvolved parenchyma. The reason to sample this would obviously be to look for GCNIS and also for another reason, because the large wings are located along the periphery of the testis, just alongside or inside of the tunica. And these are the wings that we need to examine to see if there is LVI. And testis is the only organ in the human body where the presence of lymphovascular invasion would make it PT2. The staging changes for lymphovascular invasion in only one organ in the body, and that's testis. So sampling these areas appropriately is important. And finally, you want to make sure you sample all the heterogeneous areas in the tumor, because sometimes you get scarred areas, and those scarred areas may contain different germs of tumor components, which would change the way the patient is treated. And the most important here is choriocarcinoma, where the presence of hemorrhage can help you. Okay, always sample. Don't omit sampling areas like this because you think it's probably just necrotic or not going to be useful for diagnosis. But it is because these are the areas that often tend to be all these little spots, spotty hemorrhagic areas, or probably areas of choriocarcinoma, because those tumors tend to be quite hemorrhagic. Okay, so the best practice for archaeotomy specimens is number one, sample the spermatic cord margin before sectioning, and then identify the spermatic cord base and the actual spermatic cord carefully. Okay, and then sample properly the hilar top tissue and adjacent tunica. And do not forget to sample the peripheral parenchyma to look for the LVI. Okay. All right, we're almost right at time, so that's all I have. So hopefully this was useful. Any questions?
Thank you so much.
Thank you so much.
Thank you.
I have one question. So we said if it goes through the spermatic cord, that will increase the stage. If it goes from outside and it's like not in the cord, that would not change the stage because it's also like going.
Well, for the spermatic cord invasion, it really doesn't matter whether it goes from the inside or from the outside. So as long as you're able to document that the proper cord is involved, it would be the same. There is one unique situation that is somewhat contentious. That if you have LVI extending into the spermatic cord, how do you state those? Because the new AJCC system actually recommends that if you have LVI in the spermatic cord that's coming out of the vessels in the spermatic cord and involving the spermatic cord stroma without direct contiguity with the main tumor, it should be staged as M1. Okay, so that's many GU pathologists don't really like it. There have been a lot of studies done, so it's still contentious. So the next AJCC changing the staging might pull it back. As of now, we just put a comment saying it is the staging says this, but it's still contentious. Okay. Yeah. Any other questions?
I had a quick question. In one of the slides, the one with the testicular neoplasm, how did you make the cancer reappear? Like there was no cancer and then it reappeared. How did you do that? So that was very cool.
Okay, what did I do? Like,
Yeah.
just a while ago. So, so I basically, I cut out a part of the tumor and then, put it as an insert picture in one,
Yes.
and then animated it so that it
Oh.
appears on click.
Oh, I'm
Right.
oh, okay.
And then I did another one like that, and that also appears on click.
Oh, okay.
Yeah,
That was really cool.
It is.
Yeah. That was,
that was fun to do. I was looking, for the longest time to have a tumor that's in the island like this, just, it was very hard to find. Okay, let me make one.